everyone to our training today. Today we're doing a birth plan building workshop. I'm so excited. It's fun. It's fun to build your birth plan and think about what your preferences are. So before we get started, I'll just kind of lay out exactly how this works and how I structure it. So typically what I like to do, if I copy and paste the template into the chat, and then y'all can grab it and you can put it into your notes if you want. I will say that I typically will create a birth plan with one of the moms in my coaching program when they're getting a little bit further along and they have been through my program, so they understand all of these different options. So I'm not sure how much birth education you've had, but you might be like, what's artificial rupture of membranes? Why would I want to avoid that? Or, and so please, please, please just drop any of your questions in the chat. I'm really happy to illustrate more in depth any of these things, and you're welcome to kind of like make changes to the birth plan as we go. I also want to make it really clear that your birth plan isn't an illustration of how things will go. It is an advocacy tool, and so that basically means that we're going to use the birth plan to give you a piece of paper where all of your preferences are illustrated really clearly so that we can gauge beforehand, is this nurse going to be a good person to support you for your birth? Or is this nurse maybe not so good of a fit if you go in and say, hi nurse, it's great to meet you. Thanks for being part of our team. Here's our birth plan. It would really mean a lot to us if you could make these preferences be met. And then maybe the nurse is like, I don't like to support upright birth or something like that, maybe that person isn't the best person for you, in which case now we know that, and it's great to know that beforehand. So we can go out to the charge nurse and we can say, hey, charge nurse, it would be lovely if you wouldn't mind getting us a different nurse because we really don't feel like this person is a good fit for us. Yay, now we know that. So that's one example of why the birth plan is so great. I do want to say as well that it's possible that you will choose something on your birth plan, and then when the time comes, you might be like, actually, I changed my mind. I'm gonna just give you the link to where the birth plan is so you can access it that way and you can go through it that way. You can also listen to this training, and then after the training, you can go in and take care of that yourself if you want to. There's the link. And that should take you to the free course, the Peaceful Birth Essentials course. I wanted to say your birth plan isn't an illustration of how things will go. You can change your mind. You could put on there, I decline an episiotomy. Yay, that's great. It's would be wonderful for you to avoid an episiotomy, right? We really don't love episiotomies around here. And that being said, maybe there's a rare circumstance that were to occur in your birth where episiotomy is actually the right choice for you. If that were to happen, you could say, I changed my mind. If provider says hey, actually, I think that you do need an episiotomy. This is what I'm seeing. You might say, okay, yes, I consent to that. So just because we're saying I don't want a thing, I decline a thing on the birth preference sheet, it doesn't mean that we're saying that there's no possibility that that thing is ever going to happen, because there always is a possibility for anything to happen in birth. What we're saying is that when I decline a thing, I do not want to be offered that thing routinely. Do not offer me an episiotomy routinely. Do not offer to break my water routinely. Do not offer cervical exams routinely, right? If we're saying I decline this thing, that's what we mean. And obviously, if you're in a situation where you feel like it's the right choice for you to choose to do that thing, you can totally change your mind. I also want to make it clear that I have no preference around what choices that you make. I want you to make the choice that really truly feels best for you. I want you to make the choice that really feels best for you. So I don't want any of you here at this training to feel like I am trying to tell you to do a thing, because I'm not. I want you to do what you want to do. Nothing I say is providing medical advice or substitutes for medical advice. I'm just here to give you evidence-based information and tools around different kinds of language that you can use on your birth plan so that you can create a really simple, clear birth plan that can be an effective advocacy tool for your birth. And I recommend that you take this birth plan and show it to your provider and go through it. I recommend that you have anyone coming to your birth to have a copy of it in hand and to have gone through it with you. And that's really important. And I also recommend that when you get to birth, that, like I mentioned before, you bring that birth plan in and you give it to the nurse and say, hey nurse, maybe I would actually have a partner, a support person, hand it to the nurse and say, hi nurse, here's our birth plan. and just get that gauge, get an understanding of how that nurse responds to your birth plan. This is how we can do pre-advocacy work beforehand, making sure that the people who are going to be here during the delivery of the baby are in alignment with our preferences, or at least respect our preferences. Sometimes providers will say something like, well, I can't force you to not to do that, so I guess we're gonna do it. Like they might be like, I'm a little grumpy about the fact you're wanting to birth in hands and knees, but I guess I can't force you to be on your back. That's common for a provider to kind of be a little bit like, I don't really love this, but I guess we have to do it. That can happen, and that's okay. Now they know that that's what you want, and you've been like had an opportunity to make that clear beforehand, not during the actual delivery of your baby when you're even more vulnerable. Every once in a while, we can run into a provider who will say like, I'm gonna force you on your back, you have to get your waters broken, cervical exams are mandatory, things like that. That clearly says that that provider does not honor informed consent and might not be a safe person for you to give birth with. And if this is something that you were to discover, yay, we discovered that beforehand, perhaps it would be a good idea to consider switching providers if you can, or having more advocacy, education, and support beforehand and also during your birth to help protect you from a provider treating you in a way that doesn't feel good. And without further ado, let's get into the birth plan at the first part, which is your birth intention. So your birth intention is what you want for your birth. Beyond like, I want a vaginal unmedicated birth, or I want a smooth epidural experience, or like whatever it is that you want, how do you want to feel when you're giving birth? And we can't go too deep into this now, but for the moms in my coaching program, I like to guide them through some specific exercises. So we're creating a deliberate container for you to get to explore, what is it that I really want for my birth outside of any limited thinking? What would the best birth ever be? To help us to really uncover how we want to feel, throughout that experience and what really matters to us. Because your birth is an initiation. It's a rite of passage. You are becoming someone new. Even if you've already given birth before, you're giving birth for the first time to this baby. And so it's something that this birth you've never done before. This role as a mother of one or two or more, you have never been before until now. So the way that we feel when going through birth sets the tone for our journey of parenthood and does shape our relationship to ourselves in that role. And so, for example, using your birth intention as an advocacy tool is a really wonderful way to help support you in having that feeling be intact, even if birth unfolds in a way that you didn't really want. There was a mom I supported as a birth doula, and she ended up choosing to get a C-section, and it was not what she wanted, but I knew that her birth, like she wanted it to be a ceremony. And so as a birth worker, I advocated to the provider and I said, could you please act like you're in church? Can you be reverent and not no small talk, right? I spoke to the nurses privately as well that were going to be in the room and explained to them, this is what she wants. She wants her baby to come into a room full of reverence. That would just mean so much to her, and I was just really vulnerable on her behalf and really open and invited them to step into that for her. And they were like, sure. And the provider walked out and he said, that was my first ceremonial C-section. It was so sweet. And she didn't get the birth that she wanted in those details, but she still was able to have an experience that really connected to what it was that she wanted, and that means so much to her even today, and that really helped her process her birth because there was still something that she wanted. So I won't go too much deeper into that. I could talk about that one for an hour, but I invite you to put something there. What is my birth intention? The next would be the attendance. So I would put down who's going to be at your birth and what their role is, so that's clear, like partner, doula, mother, a friend, and write that out. I would also say that you either accept or decline the presence of students or additional staff. Some hospitals are teaching hospitals, others are not, so it depends on where you are, but there's a possibility of running into students. Students are sometimes a welcomed presence and they can be really supportive. Other times moms can feel observed, overwhelmed by extra people in the room that they don't know and don't really have a specific purpose there. Every once in a while, a provider could maybe like ask a student to perform a thing depending on what kind of student that student is. And you might be comfortable with that, might not be comfortable with that. I have seen providers say, I'd like to check you, and they do an exam. And then the student also wants to check, but we need the provider to check too to confirm the student checked and got the right number. So you're getting like multiple exams, which is like not safe if your water is broken, because that increases the risk for infection. So that shouldn't happen if your water is broken. Multiple exams, if your water isn't broken, is okay if you're okay with it, but a lot of moms in labor feel like it's hard enough for me to like stop what I'm doing and get on my back and for you to check me right now. Doing that twice just doesn't really feel supportive. So it's up to you, but it's okay to decline that if you don't want that. Then let's go into labor. So I accept or decline artificial rupture of membranes. Artificial rupture of membranes is when your provider will come in and routinely break your water. I'll say like routinely is one way that they can do it, but also sometimes artificial rupture of membranes can happen on a case-by-case basis if for some reason your provider wants to do something to speed up your labor. It has been seen in observational studies that breaking your water can make labor faster, but it's not evidence-based because no randomized control trial has seen that it can make your labor faster. I have personally attended many births where we have told, not me, but the provider communicated to the person giving birth, if we break your water, you'll have your baby really soon, and then 10 hours go by and we still don't have a baby. So that is something that can happen. And so if for some reason we break your water and then you don't go into labor soon, the risk for infection really starts to become present, especially if we're doing lots of cervical exams. Other risks to breaking your water include baby's heart rate temporarily going down as they descend in the pelvis quickly. That can cause a vasovagal response. It could also cause a cord compression. Epidural or no epidural, if the heart rate goes down, it's ideal to get into hands and knees as soon as you can, because hands and knees can give baby lots of oxygen and support resolving a cord compression issue sometimes. Rarely, the cord could slip in front of the baby's head. This is called a cord prolapse. This is very rare, but it's very dangerous. And in that case, a C-section would be required for your baby's life. So to kind of summarize that, and once again, I will say I could talk about all these interventions probably for an hour each to really lay it all out for you. Just kind of going over like a quick overview so that you have some information to consider. So artificial rupture of membranes can maybe make your labor faster, but we haven't seen that in any randomized control trial. So it maybe has a benefit, maybe not. Maybe on a case-by-case basis it can. And the risk would be that it could cause their baby's heart rate to go down, often temporarily, and it increases the risk for infection. The next would be routine cervical exams. This one I could definitely talk about for an hour. So I will just say, if you don't want routine cervical exams in your labor, that's totally okay. You have the right to say no to any intervention you don't want. So if you don't want a cervical exam, you don't have to get one. It's up to you. Cervical exams are normally done upon admission when you first arrive, or if you're having a home birth when your provider comes to you, and then every 4 hours or so, and then also before pushing. That's typically what routine exams look like. So if you're not wanting to do that, you can always just say, like, don't offer me routine exams. They'll probably still offer one upon admission unless you're doing a home birth and the midwife doesn't feel like they need to do as many exams, or they're a little more hands-off. But in a hospital, typically they'll offer you an exam in which you can say no to if you don't want one. And it's totally okay to get one if you do want one. If you feel like, I don't really want the routine exams, like I just prefer to get them only if I need one, you can say the language that I encourage my mom to use: I am open to an exam if it gives me meaningful information to change the course of action. So if an exam will give you some information so that will help you figure out what to do next, that can be a helpful use of that tool. Like, the labor has been taking a long time. I have a lot of pain in my back and my contractions are kind of spacing out and getting kind of wonky weird in the pattern. What's going on? And if we figure out, oh, my baby is like kind of coming down, like facing a little bit to the side, like leaning to the side and like facing forward maybe. This position is a variation of normal OP, but every once in a while it can make labor a little bit longer and harder. So if your baby is like putting pressure on your cervix, but they're leaning a little bit to the side like this, it's the baby putting like good, even adequate pressure on the cervix. cervix that stimulates your brain to release oxytocin in these spurts, so that like in continuous spurts, we're getting oxytocin released, we're getting a normal contraction pattern. So if we find out like, oh, the baby's kind of like that, they're not putting good pressure on the cervix, okay, that makes sense. That's why things are kind of stalling out. Now we know what's going on. And if you're in my coaching program, you'll learn like what to do in every single situation. If the baby's in that position or that position or that position, they say your baby's facing forward or high up, there are things you can do to resolve that. And so doing those things then, using those positions, is like what you could do then to fix it. And that's a great reason to get a cervical exam. I'm reading a comment. I heard that rupturing the membrane can be good to avoid the baby pooping in the womb and causing problems. Do you have any thoughts or more advice on that? Oh, and yes, I can type the phrase out for cervical exam. So first I'll say no, breaking the water does not reduce the risk for meconium. So really the only benefit to breaking the water is that maybe it'll make the labor faster, but that's the only benefit. And that benefit is considered to be a myth, like it isn't evidence-based. So I would say there really isn't a lot of benefit to it. On a case-by-case basis, maybe for that particular person in that situation, breaking the water might have an effect for labor to be faster, but it doesn't always. And the phrase is, I should put this in the birth plan template too, but I'm open to getting an exam if it will give me meaningful information to change the course of action. So you can put that in there. You can also say like, I will request one if I want one. You can also say on your birth plan when it comes to cervical exams, like maybe you'll say, I really don't want to know the number. So can you just use encouraging language instead? That's something you can say, like, don't tell me the number. Don't tell me the number if it's below 5. If it's above 5 or 6, you can tell me the number, right? And I think it's good for everyone to just say, like, please use encouraging language, because someone could check you and they could say, you're only 4, you have a ways to go. Rude. You know, that's so rude. That's like not a nice thing to say, but people have said that before to moms in labor, and it's really not okay. So just saying like, it would be great for your support person when you arrive to the hospital or when your midwife comes to your house or when you arrive to the birth center, we're going to give the birth plan to the midwife or to the nurse and say like, hey, you see this part where like with cervical exams, like we really don't want cervical exams without encouraging language. Don't say the number if it's like a really small number, and kind of go over that with them. If you're having a home birth with a midwife, you'll probably already have this conversation prenatally, and so they'll know that about you. But it's just a huge difference between someone checking you and saying you're 4, you have a long ways to go, and someone saying like, wow, your cervix is making so many great changes, you're doing such a good job, keep doing what you're doing. Also maybe saying like your baby's in a good position, you're effacing a lot, so there's a lot of, which is when your cervix thins. So there's a lot of different things that we can get from a cervical exam, not just like the position of your baby and how dilated you are, right, which are like the main things we look at, but also how effaced you are and how well applied your baby is to your cervix. Are they down low? And for time's sake, I can't go into that one too much longer, but maybe I'll do a training on cervical exams sometime soon so we can talk about that more. The next would be, I accept or decline Pitocin for augmentation. You can say, if the need for augmentation arises, I prefer to use position changes, releasing my own oxytocin, or pumping first. So you just have some of those alternatives listed out. I think that can be helpful. If you're okay with Pitocin for augmentation, which means if they think your labor is taking a while to help your labor speed up, you can say I consent to that or I accept that if I need it, or something like that if you want. I will say briefly that something called the Friedman's curve, which is a labor curve that was created by Dr. Friedman in the 1950s, is very outdated and not evidence-based, but we do have research that shows that half of doctors in the United States are not following the ACOG 2014 updated guidelines on how long labor should be, and instead they're following the old outdated Friedman's curve, which doesn't give you a lot of time in labor. And failure to progress which I would say in many cases is actually a failure to wait, we have found is one of the leading diagnoses that leads to a cesarean or augmentation of labor. And there are risks to Pitocin, and we don't have time to go over all of that today. But I think it's important to learn more about risks, benefits, and alternatives to Pitocin and have communication tools to kind of have that conversation and know really how long you have to labor, so that you're educated if that were to pop up. If someone were to bring up like, hey, I think that you need a C-section, your baby's heart rate is kind of concerning. If we're in a situation where it's not an emergency, and you can always clarify, is this an emergency or do we have some time? Are you like really concerned about the baby, or are you like not so sure and kind of leaning more towards we should try to figure out something to fix it, right? Because there are shades of gray with fetal heart monitoring in labor. One provider might see a tracing and say that's concerning, C-section, and another provider might see the same tracing and say that looks normal, because your baby goes through a normal variation in their heart rate from 110 to 160. It's normal for them to have that variation. Variation can look a lot of different ways, and we have to interpret that, and sometimes we can't be totally sure. And so providers will often lead more towards C-section. So if a provider came to you and said, I think that you need a C-section, you can put on here, if that situation were to arise, that maybe you want to do like different alternatives first if there isn't an emergency. So this is optional. You can say something like, if there are non-urgent heart tone concerns, I prefer to try, and this is I'm reading this from the birth plan template I sent you, I prefer to try an amnio infusion. An amnio infusion is where they can take a tube and put it past your cervix into the uterus and have fluid like flowing in, and that gives baby like a cushion, and that can help with their heart tones. You can also say, I prefer to try upright positions too before a cesarean. If you're on your back or even sometimes lying on your side, baby can not tolerate labor well, and that's because a little cord compression could happen. Side is so much better than on your back, but lying on your back can compress a blood vessel that runs behind your uterus because your baby's putting pressure there, and so that can really increase the risk of baby just not doing so well because they aren't getting as much oxygen. So you just getting in hands and knees and moving your body, getting in upright positions could potentially help you avoid a C-section. And there was a mom in my coaching program who had her baby last week, and she, under threat of C-section, like her whole labor, they kept bringing it up, but it wasn't urgent. It was just like, maybe baby's not tolerating things well. And they really wanted her on her back so they could monitor better. It would just made their job easier, but being on her back made the heart tones worse. So she really advocated for hands and knees. She had an epidural and she was moving side to side, hands and knees, and she was just moving around a lot with support. And she had to really fight and advocate for that, but she had a vaginal birth and her baby was perfect because she understood those alternatives. So will pumping actually help in that case? Should you pump before going to the hospital once you are already in labor? Yes, pumping can help to augment your labor or speed it up sometimes. It could also help induce labor, though rarely pumping it on its own will just induce labor. Usually if we want to induce, we want to combine a lot of different tools in addition to pumping. And I do have a labor induction formula that you can access. You can always reach out to me if you want to know where it is. It's in the academy. But you don't have to pump. Like, your body knows what to do and normal physiology works really well, and we don't have to mess with it most of the time. So pumping is a tool that you can use if for some reason your labor is taking a really long time, you're getting kind of exhausted, and we want to do something like maybe your uterus is getting tired and not like contracting very well. I will say another option to augmenting your labor or to speeding it up could be you eating some food, like eating some grapes and sipping on a protein shake, because not eating and drinking during labor leads to reduced uterine efficiency. So maybe we're creating a problem by starving you in labor and trying to fix that problem with Pitocin when we could prevent that problem potentially with eating and drinking. And every once in a while, someone's uterus can get really tired and they do need some augmentation, but that is pretty rare. And there are some alternatives you can look into if you want. And so the next one is, I will wear my own clothes. You can leave this out if you're planning to wear a hospital gown, but if you don't want to wear a hospital gown, wear your own clothes. If you're having a home birth or birth center birth, that's already implied, so you don't have to have that. And then photo and video will be taken. Once again, you can remove that if you don't want it. You have the right to video and take photos of your own birth. If someone doesn't love that, you can compromise with providers and say, okay, like let's say doula is recording. Doula will record the mom or the person giving birth and will not record provider. So we'll just face the camera at the person giving birth. And that's usually a good compromise, but just know you do have the right to photo and video your own birth. Next, let's talk about monitoring. You could say, I accept or decline continuous monitoring, even if it's wireless. And then if you do choose continuous monitoring, you can say, I prefer external or internal monitoring. And then I accept or decline intermittent monitoring. So continuous monitoring is a form of monitoring throughout labor where we have these two, they look like little hockey pucks, circles that go on your belly. One goes on the top, one goes on the bottom. The one on the top is going to listen to your contractions and will show the nurses at the nurses station who are probably watching digitally what is going on with your contractions, what the pattern is. And then the other one is over the baby's heart, and it will monitor the baby's heart rate continuously all throughout labor. And what we have found is that continuous monitoring increases your risk for a C-section without improving outcomes to babies. We have found no differences in NICU admission, APGAR score, which is a score to assess how well the baby is doing and things like that. So it is safe and evidence-based choice to choose intermittent monitoring over continuous monitoring if you're a low risk person, if that's something that you want. And low risk is defined differently by different people. So if you're ever confused about it, because some people will say, oh, I'm over 35, that means I'm high risk, right? Like being over 35 doesn't mean you can't get intermittent monitoring. Having gestational diabetes doesn't mean you can't get intermittent monitoring. Things that are kind of gray, like if you get Pitocin, do you need continuous monitoring the whole time, or is it okay for just a little bit and then you can like go back to intermittent? And some organizations have some rules about this, but we don't have a lot of research on some of those specific situations that are a little more high risk. But you can talk to your provider about it. You can always get a second opinion too if you want. Some providers are really friendly to continuous monitoring and that's what they want to do, and other providers are more evidence-based in the way that they practice and routinely offer intermittent monitoring for low-risk moms who want it. Intermittent monitoring means that you're being monitored intermittently, so every 15 to 30 minutes throughout labor, and typically more frequently around the pushing stage, so around like every 5 minutes or every other contraction or something like that. So I'll leave that there. I will say that for the continuous monitoring options, there's the external option. You could also do internal if you want, and you can make that preference clear on the birth preference sheet if you want to. Internal monitoring is where they take a little coil and it spirals into your baby's scalp, just into the skin on their head. You do have to break the water in order to do this, and that does come with its own risk, but perhaps the water is already broken. And then there's an intrauterine pressure catheter that's placed inside of your uterus. So your uterus will contract and will monitor the contractions. It also monitors the strength of your contractions. I haven't yet seen a time where that was like something that was really important information to have, but it does that. And then it's also monitoring your baby continuously that way. It does come with an increased risk for infection, and it can lead to, I will say it's kind of annoying because you have tubes in your body and you can't travel too far away from the bed with all these tubes in your body. So that's something to be aware of as well. And there aren't really many benefits to internal monitoring in comparison to external because both of them are accurate, but sometimes external, the baby moves and we have to come in and move the monitor, and baby moves and we have to come in and move the monitor, and people are kind of like fussing with you and it can be annoying. The straps can be annoying. So some people prefer to do intermittent for that reason, and that's totally okay. Okay, let's move on to IV access. You can say, I accept or decline the IV HEP lock. You can also say like, I accept the HEP lock, which is an IV lock, a saline lock. So they'll put it in your hand or into your wrist, most likely. Rarely they'll put it in your arm. It's really ideal to not have it here because we want to be able to bend our arms. And that will give them access if you're in a hospital or home or birth center. All midwives that are licensed have the capability to give you an IV if needed. Some providers want to have that there in case there's emergency and they want to have access to your veins, which is understandable. I will say though that as a student midwife of many years and someone who has attended many, probably over 55 births at home or a birth center, so out of hospital, rarely did I see anyone getting a HEP lock during labor or needing an IV. It's a personal choice. If you don't want the HEP block and you are a low risk person, you're not planning to use medications during labor, that's a choice you can make, and you can talk to your provider about it and see what their thoughts are. Also, the other point or the other part to this is just considering if you're a high risk person and if you have any like unique need to maybe access your veins, like you're planning a medicated birth, or maybe you really struggle, like you're afraid about dehydration or something like that, and you might want to do IV fluids. If you are high risk for hemorrhage, maybe you have low platelets and they've communicated to you they're concerned about hemorrhage, perhaps getting a HEP block would be good. They can give you medications for hemorrhage without an IV, but if you're having a bad hemorrhage, which means you're losing a lot of blood and your uterus isn't very responsive, having continuous IV fluids going into your body with Pitocin specifically will be like more supportive, if that makes sense. What are the potential benefits to have an IV? So let's talk about that. So you can get the HEP block and not the IV if you want, or you could get the IV too if you want. Continuous IV fluids in labor have some risks. One of the risks is that they could increase the risk for swelling and your body holding a lot of fluid. That can lead to your nipples flattening, and that can make it harder for your baby to latch. Continuous IV fluids also increase the risk for tearing because they can cause your perineum to swell. And there is a rare side effect called fluid overload, which means we give your body too much fluid. That could sometimes lead to an electrolyte imbalance, and that can be very dangerous and even life-threatening. That's very rare, but it is something that is a possibility to be aware of if we just continue to do IV fluids all throughout labor. IV fluids can be beneficial if you're dehydrated. They can be beneficial if you are needing a medication to be continuously infused into your body, like IV opioids or Pitocin or something like that. And I will say that we do have research on the difference, quite a bit of research, between eating and drinking during labor and just doing IV fluids for hydration and not eating, and we found that outcomes are better with eating and drinking normally throughout labor. Which leads me to the next point, which is I will eat and drink as I feel is needed during labor. This is something you can choose to do, or you can choose not to do it if you don't want to either. We have found that not eating and drinking throughout labor increases the risk of reduced uterine efficiency and of you getting exhausted. You need fuel. So imagine you are running a marathon, because birth is expending the metabolic output of a marathon. And so if you're running a marathon, we want you to be hydrated and to have good food in your body and to take care of yourself and give you the fuel you need to do the thing your body needs to do. And so moms who aren't eating anything or drinking anything during labor and just getting IV fluids found that increases the likelihood of them getting really exhausted and not having the energy that they need to do the thing that they need to do, and for their uterus to do the thing that it needs to do too. The concern is that if we need to put you under general anesthesia for an emergency C-section, C-sections we often have time to give you an epidural or a spinal, or maybe you already have one, but if we don't have time under general anesthesia, there's a risk for you to throw up and then aspirate. That's what they're concerned about. But that comes from earlier in the 1900s, when providers were using different anesthesia techniques compared to today. So we have found for low-risk people, it is a safe and evidence-based choice to eat and drink throughout labor if that's something that you want to do. And it's a human right. So you have the human right. No one can deprive you from food during labor, even if it's policy. Policy is just policy, and you have the right to make whatever informed choice that you want to make. Okay, let's move on to labor coping. Options for this would be, I plan for an unmedicated birth, do not suggest pain medications. Or you could say, I want or I'm planning for an epidural or nitrous or IV opioids in labor. I will request it when I'm ready. You could say I will request it when I'm ready, or you could say you can offer it to me if you want. It's ideal to wait for the epidural until you are beyond 5 or 6 centimeters if possible. That can decrease the risk of the epidural slowing down your labor. And so this is why it might be ideal for you to request when you're ready instead of being offered, so that we aren't getting it earlier than we need. Also, if you're wanting an unmedicated birth, I think it's really important to say do not suggest pain medications, because you might get to a point where you feel like you're facing your own self-doubt, which is normal. It's normal to face self-doubt when you've done something you've never done before. You are becoming someone new. And so as we become someone new, we sometimes kind of go, can I do this? And we might face moments that feel hard. And so if someone right in the moment when you're like, I don't know if I can do this. This is feeling really hard. And then someone says, well, I can get you an epidural. You might be like, okay, yeah. But sometimes that's what you need. But other times, maybe you just need more support, more emotional, more physical support. And if you're in my coaching program, you will create a plan for you, like a personalized plan around how we're going to address that. And this is how I've had dozens of moms go through my program who were third-time moms specifically and got an epidural at transition each time. And then with their third, they came to me, and a mom just had her baby last week. I'll announce the baby's birth probably in the next couple of days, but she did it. And she actually had a 22-minute, like by the time she got to the hospital, it was 22 minutes before the baby was born. And she had the tools that time. And so the tools is really like what will help you get through those moments. So we don't want anyone in those moments being like, your only tool is an epidural if that's something you don't want. If that's something you do want, then that's okay too. And then the next thing you can say is, I will use low light, movement, water, and comfort tools. You can say whatever you want here, but especially for someone planning an unmedicated birth, some moms will like bring in a birth plan and it's like a list of bullet points of like, I want to use the TENS machine, the rebozo, the ball, the water. And I don't think that is as necessary. Maybe you could create a plan with your doula around the ways you want to be supported. This birth preference sheet is for providers, for an advocacy tool. So we don't need to have all that there, but we should make it clear that you want the lights low. If you do, you want to move, you want to access water, and you want to access comfort tools. And you can also specify, please bring me like the peanut ball and the birth ball. If you're in a hospital, birth centers will have a lot of these tools, and at home you can get whatever tools you want already and like have that there before your birth. Next, let's talk about pushing and delivery, which is a fun thing to talk about. So I will push instinctively. Do not coach me to push. This is one option. If you're wanting to experience the fetal ejection reflex, if you want to have a spontaneous pushing phase and you don't want directed pushing, you can use a phrase like this. If you want directed pushing, you could say, I consent to directed pushing. If you don't want to be coached, but you're like, well, if I feel like I need support, I might want the support, you could say something like, do not coach me to push. If I need support, I'm open to gentle guidance. And gentle guidance is different than directed. It means that we are, as a doula or provider or birth worker, gently guiding you to get in whatever position feels most comfortable for you, to engage your tummy muscles with contractions and kind of bear down, listening to your body. It's less get on your back, pull your legs back as far as you can, and bear down to the count of 10 and push as hard as you can. And a little more like, it's like self-guided, but you're getting a little bit of that guidance, if that makes sense. And it would be good to go over this with your provider, and they might be like, what's gentle guidance? And then you can say, well, this lady on the internet said it's this thing, and that's what I want. I really don't want to be on my back with my legs back and people yelling in my face, but I'd be open to someone gently guiding me in whatever position I want if I feel like I need that. So you could pop that there if you want. I recommend that everyone says on their birth plan, I decline episiotomy. If you're comfortable putting that there. A lot of moms will say, I prefer no episiotomy. And a provider with a high episiotomy rate might see that and be like, yeah, of course, nobody wants it, but you might need it, And yes, there are very rare circumstances where an episiotomy might be a good choice for someone, but the evidence-based episiotomy rate is 1%. So that means that of everyone in the whole world and all the different things that can come up with birth, 1% will actually need an episiotomy in a life-saving situation. If your provider has an episiotomy rate that is evidence-based, you can say, how often is an episiotomy needed? Or I really want to do what I can, like whatever I can to avoid it. Is there like things I could do to help me reduce my risk? If you ask them questions like that and they're like, yeah, I've only done like a handful of them in my whole career, that sounds very evidence-based to me. But if you tell your provider that and then they're like, well, sometimes you just need one like that, it's like, I don't know about you, like that sounds like maybe not so evidence-based to me. So you can also just ask for the rate. If your provider has a high episiotomy rate, it may be worth considering choosing to birth in an upright position, choosing provider hands off or hands poised so they're not touching your body automatically when baby comes out. These are ways, evidence-based ways to reduce your risk for an episiotomy. If they don't have a high episiotomy rate, then you probably don't have to worry about having that in there. I will push and give birth in whatever position I choose, and then reduce tear risk. So you can say, I accept or decline a warm compress, Warm compress is a warm washcloth that can be placed on your perineum in the pushing phase. And that is an evidence-based way to reduce the risk for tearing and to reduce the risk of pain during birth. So I highly recommend you do that, or I accept or decline perineal massage. So you can do a perineal massage in pregnancy. I did a training on that recently and I just got the video, so I will be uploading that hopefully today and I'll post it, so I encourage you to go watch that. That's different. Perineal massage during pushing, some people believe that that's like the best way to help you reduce the risk for tearing. A lot of providers will perform perineal massage. The problem with that is that provider hands-on does increase your risk for tearing in episiotomy, especially if your provider doesn't have an evidence-based episiotomy rate. Fingers in the vagina can be overwhelming. Sometimes it can be unwanted, but you don't know that you can decline. Also, providers may do things unnecessarily, like stretching the vagina open when baby comes down, putting pressure on the perineum. Like, these techniques aren't evidence-based, nor are they actually helpful, and they could be harmful. It's important to recognize that you always have the right to autonomy, even with the baby coming out of your body, and no one has to put their fingers in your body or do anything like that without your consent if you don't want that. If it feels supportive to have someone put a little pressure to give you a focal point to know where to push if you're not getting the fetal ejection reflex, sometimes that can be helpful. Or if you have a really tight band of tissue, then relieving that can help the baby come down. There are rare circumstances, right, on a case-by-case basis where perineal massage during pushing can be helpful, but we don't have any good quality research that shows that it decreases the risk for tearing. So it's not evidence-based. The only good quality research that we have on perineal massage during pushing is that it's in populations where there is an 80% episiotomy rate. So if you tell half of providers to like massage people instead of cut them, then yeah, they're probably more likely to, or they're less likely to cut someone because they have something else to do with their hands. But that research doesn't apply to our population, where we have a 10 to 15-ish percent episiotomy rate in the US, which is still way beyond evidence-based, but that's much better than an 80% episiotomy rate, if that makes sense. So it's not evidence-based, but it is something you can do if you want. Maybe on a case-by-case basis, it could be helpful. It should only be performed with your consent. That's really important. Informed consent means you understand the risks, the benefits, the alternatives. You understand that you can say no. So someone saying, I'm just going to do some massage, that's not consent, that's not evidence-based, that's not okay. Someone saying like, would it be helpful if I performed a little bit of perineal massage, and you saying, yes, that's fine with me, and you understand the information, that's consent. Looks like we got another question. Would a good win-win be accepting massage by a husband or with husband supervision? Yeah, I would say it's good to have your support person to be there and to just like keep an eye on the things that are happening. Let's say you're birthing on your side and provider comes in and sits down on the stool and gets gloved up, and they're like, oh, okay, like, hi dear, looks like you're about to push. I'm just gonna check and see what's going on. You know, they like will start doing something perhaps. They shouldn't, but that can happen. Maybe I'm gonna just reach in and feel for the baby's head and see if they're there. Or like, I think I need to make a little cut. I'm just gonna give you a cut, and they'll like grab the scissors. You know, if your partner's right there or a support person, they could just say, I see you're picking up scissors. And then they could say like, honey, did you consent to that? Is that okay? Or maybe they'll say, I see you're going to do an exam. Is that okay with you, honey? Like, they can use their own intuition if they ever feel funny about something or they see something happening without informed consent in place. They can just vocalize and be kind of annoying about it. I see you're picking up scissors, right? Or like, wait, stop, what are you doing again? Can you explain to me what's going on or why you're doing that? That is like a good advocacy tool for partners. It's only a win. The win would be whatever feels good for you. And if the provider wants to do it, but they don't get to do it, tough luck. It doesn't matter. Like their preference on how they want to do things, if it isn't about like your safety, it doesn't matter, if that makes sense. Yeah, so like they're going to be okay if you say, I don't want that exam, or I don't want perineal massage, and maybe they're like, but this is what I used to do, like you could tear if I don't do it. We know that that's not evidence-based. Maybe that's just the way that they practice, but they're going to be okay if we decide to say no. And yeah, you totally could have your partner do the perineal massage. You could have your partner do the warm compress too. If you prefer them to touch your body and not your provider, you're welcome to do that. I don't think it's necessary for partner to do perineal massage when pushing though, because it just isn't evidence-based. But warm compress is evidence-based. Is there any point where we should be okay okay with them taking the scissors and cutting. No provider should just pick up scissors and cut without your consent. How that should go is that they should maybe say, the baby's heart rate is down really low. We need to get them out soon. Can I perform an episiotomy? Or like something like that. Like they should ask you first. If anyone sees someone going near you with scissors, they should say, stop, what are you doing? And it really only takes a few seconds to get consent. Like truly, for a provider to say, the baby isn't doing well, this is an emergency. And if partner says like, wait, stop, what are you doing? And provider says, it's just a little tight down there, like we just need to open up a little space. You can say, stop, we're declining an episiotomy, something like that. Like, stop, we decline an episiotomy. Is this an emergency? Just like clarify that. And if they say like, no, it's not an emergency, but it's just like something that we need to do, it's kind of a tight fit, it could become an emergency, right? That's clearly like not an emergency. An emergency situation where episiotomy would be necessary is if the baby's heart rate drops really, really low suddenly, and maybe you're having a long crowning phase, like over several minutes, and then we see suddenly like the baby's heart rate goes down really far, and we need to get the baby out right away. That would be a reason to do an episiotomy. I will say it's normal. It's called the dive reflex, where baby descends really quickly and they're about to come out and their heart rate goes down a little bit. So a baby's heart rate, I mean, I'm not a provider, okay? So I don't want to say like for sure this is right and this is wrong, but maybe I'll just give you some examples from what I've witnessed as a student midwife. I've attended many births where the baby suddenly was at the perineum, like they came through really quickly, and I'm listening to heart tones, and the heart tones are now 80 or 90, and they should be 110 to 160, and all of a sudden they're like 80. And I look at this one story, I remember I looked at the midwife and I said, call 911. Like, I'm kind of worried about that. I didn't feel comfortable with how low the heart rate went. And so someone else called 911, and then the baby came out and the baby was fine. So babies do have the ability to tolerate some kind of oxygen deprivation. With that midwife, I did not attend this birth, but she told me the story. This was the first episiotomy she ever cut in 20 years of her career. And in that situation, the mom was pushing for a while. There was a really tight perineal tissue. The baby's head was right there, but I think because of the tight perineal tissue, the baby had a hard time coming all the way out. And if given time, the baby would have come out, but like that wasn't really the issue. It was mostly that the heart rate just wasn't doing well anymore, and it dropped down very low. The midwife put the Doppler on and it was like ba-bum, ba-bum, or something like that. It was like 40 or 50. That's very low. If a baby's heart rate is 60 beats per minute or below, that's when we need to do chest compressions in neonatal resuscitation. So like, 80 and 90 and 100, that's low and that's concerning. Is it episiotomy concerning? I can't say because I'm not a medical provider, but I have assisted many births where a baby's heart rate was in that place, and we used other methods to get the baby out rather than episiotomy, and each time it was fine. But with that case, the provider looked at the mom and said like, the baby needs to come out, and the mom said, cut me, because the mom knew in that moment like, this is an emergency, the baby needs to come out right now. And so they did that, and the mom felt okay about her birth because she was part of the decision-making process. She made that call with the midwife. Something wasn't just happening to her body without her consent, if that makes sense. Okay, let's go to the next one, which would be myself. Provider or partner will catch the baby. So you don't have to say provider will catch the baby if that's your plan, probably. But if you want to catch the baby yourself or you want your partner to, it's important to clarify that. And it's also important to clarify, especially if your provider is way more hands-on and you want a hands-off birth, to clarify that that's what you want. If you want, for example, your partner to catch the baby, sometimes what that looks like is partner's hands are on the baby, and then provider's hands are on the partner's hands, and then you do the maneuvers. Like the provider performs the maneuvers to kind of pull the baby to get the top shoulder out and then pull the bottom shoulder. And so that is something that could happen if you're okay with that. But if you just want the autonomy to like you and your partner catch your own baby, you can just say like, myself and my partner will catch the baby. We choose provider hands poised, or we choose provider hands off, which means the provider's hands are there and they can step in if needed, but the provider doesn't have to step in routinely, and you are preferring that they don't step in routinely. Most of the time, babies will just come out, and you have the ability, you have the instincts to catch your own baby if you want. It's your baby. Every once in a while, the shoulders can get a little stuck, or maybe the baby's heart rate is going down, in which case we need someone to be more hands-on, try to get the baby out faster. But if your baby is doing well all throughout labor, there is not a medical reason, and all throughout pushing, right? There isn't a medical reason for anyone to step in, then it's okay to let your baby just come out. And most of the time they will come out without being pulled or tugged on, or without any kind of maneuvers happening. So it's up to you, whatever would feel most supportive for you. It can feel really supportive sometimes to have provider like do the maneuvers and guide the baby's body out, and other moms just feel like, please don't touch, I want you to step back. I want baby to just come out into my partner's hands, or I want them to come out just onto the bed. If I'm kneeling right on the bed, they're like my vagina, and the surface of the bed is like this far away, they're gonna just land right on the bed, and I don't want anyone to touch me. That's okay. If you want provider to catch you, that's also okay, but it's just important that you decline that or consent to it and make it clear what your preferences are here. Let's go over immediate postpartum. Do not clamp the cord until I give you verbal consent. I just lean towards the most firm language because I don't know how providers will be. But if you really trust your provider and they do delayed cord clamping in the way that you want, then all you have to say is like delayed cord clamping. Some providers define delayed cord clamping as delaying it for 60 seconds to 90 seconds or 2 minutes. Other people want delayed cord clamping, meaning to them, we wait until the cord is done pulsing and kind of turns a little white. So it's up to you what you want to choose. If you say I want delayed cord clamping, we might be leaving what that is up to the provider. And if you're not okay with that and you want it to be different, it might be good to specify, or you could just leave, I would say, keep the power in your hands, right? Do not clamp the cord until I tell you it's okay. I don't want you to do it. I'll let you know when I'm ready, So you're in charge of that if you want. You could say who's going to cut the cord. And then you can define if you want Pitocin after your baby comes or if you don't want Pitocin. So Pitocin is that medication that can help your uterus to contract. There are way more risks to getting it in labor compared to getting it after your baby comes out. It is an evidence-based way to reduce your risk for hemorrhage or heavy blood loss. And I personally, like with myself, I didn't get it the first birth. I didn't need it. With my second birth, I did expectant management, which means we're gonna only give it to me if I need it. And I ended up needing it. And with my third, I decided just give it to me. I just want it. So, because I don't want to bleed very much, and I did bleed a little more with my second. So there aren't a lot of risk to getting it. I will say, there was a study that came out that said getting Pitocin could mess up your hormones, and then evidence-based birth said that study was so bad, we're shocked it passed peer review. So it's not evidence-based that getting Pitocin messes up your hormones. Any risk to getting an injection if you don't have an IV and you're getting a shot of it, which is typically how a midwife would do it in an out-of-hospital situation. If you needed a lot of it, then they would give you an IV with it. You would have there's risks of pain or swelling at the injection site, right, with an injection. And if you get a lot of it postpartum, it could cause the swelling in your nipples to flatten, but just a little bit, giving you some routinely just to prevent or reduce the risk for heavy bleeding should not be very much. And you can ask your provider what that amount is if you want. Okay, the next would be, do not touch or rub my baby with blankets unless they need resuscitation. And so this basically means what we're asking here for the provider to, when the baby comes out and baby's put on your chest, we are saying here, if you want to keep that in, you don't have to, but if you're wanting to, we don't want a nurse on each side and provider to all be using blankets and rubbing the baby up and down before you even get a chance to see your baby if your baby's doing well. Rubbing the baby after they're born and stimulating them and drying them is step one of neonatal resuscitation. So if your baby needs to be resuscitated, please do that. That would be great. We want to rub and dry and stimulate the baby, yes. And sometimes that's all the baby needs to kind of come around. But if your baby comes out and they're pink and they have good tone, which means they're kind of like this, or they kind of will have a fist. They're not floppy, they clearly have good tone. Their hands and feet will be pink, but their chest and belly will be pink. They have respiratory effort, so right after they come out, they're kind of like, wah, they cough a little bit to kind of get some fluid out of their lungs and they start crying. Yay, that baby's transitioning well. Does that baby who is transitioning well, who has a good APGAR score, which is a score to assess how a baby is doing after birth, does that baby need resuscitation? No. So do we need to dry and stimulate the baby? No. We should warm the baby. Like every baby needs to be warm. They can lose heat quick, and being wet and just in a room where there's a draft or being wet in general can make your temperature go down. So we want the baby to be warm, but do they need to be like rubbed aggressively with blankets if they don't need resuscitation? They don't. So it's up to you. If you are fine with them doing whatever they want to do, then do that. If you feel like I really don't want a bunch of people touching my baby after they're born, I want to be left the heck alone, that's okay too. It's very valid. So you could say like, please hand me a blanket, or just put a blanket on my baby, but otherwise leave us alone basically. And if the baby's skin to skin with you, there's a blanket on the baby, then that's all the baby needs, right, to be warm. Rubbing the baby can also wipe the vernix off, and we want to keep the vernix on because the vernix has a lot of benefit to your baby. So rubbing it off unnecessarily might have some downsides. So the next is the release of the placenta. You could say, I want physiological placenta release. Do not pull on the cord, which would mean you just want to wait until your body's ready. You want to wait till you feel some cramping, you feel pressure, and you kind of want it to come out. And you might want to hold the cord yourself and kind of guide it out. You could also say, you can help me deliver the placenta with gentle traction. And you could also say, you can help me deliver the placenta with gentle traction, but do not pull on the cord. Just taking the cord and pulling, which I have heard many stories of. I have seen that happen. That can leave chunks of the placenta inside. I have seen that happen. We don't want that at all. So there's a difference between pulling on a cord and just putting downward traction. Traction means we push it down, and pushing it down allows it to come out, or supports it in coming out. And we can assess and do a little traction and see, is the cord elongating? And if the cord isn't elongating and it's still inside, the placenta is like clearly still like latched on, then we just like want to wait a little bit. And I could talk about the placenta also for forever, but just to give you kind of a little bit of an overview of some options, you do have options there. It's really ideal not to have anyone pull on the cord, but gentle traction can be really helpful because sometimes it can release and then it's just sitting there above your cervix or something, or even in the vaginal canal, and it can block blood, so your provider won't be able to assess blood loss. If it's sitting in the uterus, it can impact your uterus's ability to contract on that open wound left by the placenta. So we do want it to get out of your body when it's ready, but we don't want to pull on it when it's not ready, if that makes sense. Signs that it's ready would be the cord elongating when we do gentle downward traction, and you would have some cramping probably, and you might feel like, oh, crampy, I kind of want to push, and your uterus is like trying to get it out. I want to keep my placenta, or you may dispose of my placenta. And then for C-section, these are just a few options. About how long does the placenta take to come out naturally? It typically takes about anywhere from 5 to 45 minutes or so, sometimes an hour. Some providers will define a retained placenta, meaning it's stuck and now you need surgical intervention or you need a procedure. I would say maybe it's not considered a surgery. I'm not sure. It's an operation where they would manually remove it with their hand. That is something, if anyone recommends to you a manual removal, that you have options, you have alternatives to try to get it out. You can get upright, you can pee, try to pee. You can even get a catheter to try to empty your bladder if you can't pee. You can latch your baby to release oxytocin. You can get Pitocin. And, if someone says it's been 30 minutes, it's like a manual removal time, just know that they're wanting to do that because they're worried about your placenta being retained and they're worried about hemorrhage. But manual removal increases the risk for hemorrhage and infection, and it's a really big deal. It's a procedure that can be really painful and increases the risk for infection, so it's something that we want to make an informed decision about. You can advocate for an epidural, IV opioids, or even to be put under for that procedure. Some providers define a retained placenta at 30 minutes. Other providers define a retained placenta at 1 hour. I have supported dozens of births where the placenta took about 45 minutes to come out, and we just did a lot of natural things, monitoring the mom's vitals, monitoring for signs of heavy bleeding, and the placenta came out. Some providers might jump to manually remove before we try any other things. There are situations where you are hemorrhaging, so you're losing a lot of blood, and the placenta has to come out, in which case a manual removal is a life-saving procedure. but it isn't necessary for everyone at 30 minutes with no other signs that they're not doing well, if that makes sense. And you have the right to get that information and make an informed choice in that moment. We have like contractions that will make us know to push it out. You should feel a contraction, and you might even feel a little pressure of it coming down. And your provider can always check by doing a little bit of gentle traction. You could also do it too, and just see if the cord is elongated and if it's coming, and if it feels like it's tugging and it's not coming, then it's not ready yet. And I believe in the free birth course, there's a little bit of more information on the placenta. And if any of you wanted to join my coaching program, you'll get like my full hour-long speech about it. We can really go deep into it. Yeah. So for a cesarean, you could say, I don't want to spend too much time on this because we're a little over our time, but I will just share a few things. So every operating room works differently, and some providers routinely do delayed cord clamping and skin to skin for a C-section, and other providers do not. I think it's good to request the things that you want. Some providers are okay with your partner being in the room and support person, and some providers prefer them to be out of the room while they get you prepped, and then they'll bring partner inside. So the options here are partner present at all times, or you could say, please have my partner enter the room as soon as they can. Please lower the screen so I can view my baby when they're born. That's something you can choose. If you are like, no, please don't do that, you can take that out. I request delayed cord clamping. This is the only time where I put the word request in the birth plan, because the birth plan is not you requesting something, it's you saying, this is the choice I'm making. In a surgical situation, if a provider isn't familiar with delayed cord clamping and isn't comfortable with it, it's understandable that might not be a thing that gets to happen, though hopefully they are. And if you're having a planned C-section, you can shop around and hopefully find a provider who will honor the preferences that you have. The baby will be brought to me immediately for skin to skin. Or you could say a partner will hold baby skin to skin as soon as they're stable. You could also say if baby has to go to NICU, the support person will accompany them and the support person will stay with me. So if like you have grandma, for example, and she's waiting outside, if baby has to go to NICU and partner goes with baby, then we can call grandma in to be with you because you put that on the plan. And so hopefully that they know that, or doula or something like that. If you want to advocate for skin to skin with your baby post C-section, which you have the right to skin to skin with your baby, you can ask for the EKG monitors to go on your shoulders, not on your chest. You could have your IVB in your hand, not in the crook of your arm, so you can hold baby and have a support person there whose job it is to monitor skin to skin, and for them to verbalize, I'm monitoring skin to skin safety. So like I'm making sure the baby doesn't fall off, which the baby, I don't see how they could because the baby can't crawl yet, but they do want someone to like monitor that. And yeah, some places do skin to skin routinely and some places do not. I will say that skin to skin after C-section, we have research that shows that it decreases infant mortality rates. So your baby is more likely to survive and transition well after birth by having skin to skin post cesarean specifically. Cesarean is so beneficial for outcomes, so vital for baby's outcomes. And because of the evidence practice gap, it can just take a while for some places to implement that. But you do have the right to that. And if you can't be skin to skin with your baby, you can have someone else be skin to skin with baby, as long as they don't have to go to the NICU. Does it have to be me, or is skin to skin with my husband also? Yes, it's skin to skin with anyone. For feeding, it'd be great if baby could be with you, but if baby can't be with you, skin to skin with anyone else, any other loved one would be great. You could have partner, if your partner is a person who does not have breasts, they could be like shirtless underneath the scrubs to make it easier to be skin to skin with baby, but it will be a little bit colder in that room, just so you know. So if you're a cold person, you might be chilly if you do that. Does feeding happen directly after labor? Yeah, feeding can happen within minutes or within an hour, but baby being skin to skin uninterrupted establishes that first feed. If baby's separated for a long time, feeding sometimes is still fine, but every once in a while it can make things be a little bit more challenging. So it's really important, if we can, to have baby be skin to skin with you so that that first feed can get established. And the last would be, I accept or decline a vaginal swab for baby's microbiome. This is not super well researched, but there's an idea that if you do a vaginal swab and rub it on the baby's mouth, that will stimulate the baby's gut and immune system. When babies go through the vaginal canal, they go through something called seeding, vaginal seeding, and so they get all this bacteria that is foundational fundamental to their health, their long-term health, because it gives them that inoculation for their gut and immune system to begin working. But it's not super well researched, so we don't know if that's something that would be really helpful for your baby or not. But you can put it there. You can look into it more. Evidence-based birth for their pro members recently released information on this, and I'm reapplying to be a pro member, so I'm going to find out soon because I'm curious what they have to say on that. Okay, the last section is newborn procedures. So skin to skin immediately, vitals taken on my chest, so no one needs to separate your baby to weigh them or anything like that. We want them on there immediately. That's important. You can put in your feeding plan if you're planning to breastfeed, if you're planning to bottle feed or formula feed. Then you can say, I accept or decline the newborn bath. After 24 hours, I put that here because we have research that shows that delaying the newborn bath for 24 hours or more is really beneficial to your baby's health, because there's lots of microbes right on your baby from going through the vagina or just being skin to skin, licking your chest. All of that is helping to stimulate their gut. So we don't want to wash all that stuff off. And vernix is great too. We want the vernix, the white cheesy stuff, to stay on your baby. We don't want it to get washed away. Question, is it possible to ask them to not take the baby to another room? Of course. So this is your baby. Please don't let your baby go anywhere else. If you are not comfortable with it, you have the right to decline or accept any intervention for your whole birth and for your baby. So no one can do anything to your body or your baby without your informed consent. No one can take your baby to another room without your consent. Some people might try. Every hospital culture and policy and whatever is different, but you can just have your baby with you at all times, or with either you or your partner or something at all times. And if you want baby to go away to nursery, that's okay too. But of course, no one needs to take your baby away. You can also say, and you'll see for these next things, the hepatitis B vaccine, the vitamin K injection, and erythromycin. If you want any of those things can be performed with the baby in your arms. If you want to do the hearing screen, the baby can be in your arms when you do that. The metabolic screen, where they do a little heel prick and get some blood from baby to test for genetic stuff, that can be done with your baby in your arms. No one has to take your baby away. And if you want them to, that's okay too, but just know that you don't have to. It's your baby. You get to do whatever you want with your baby, and your baby can stay right in your arms the whole time for all those things if you want. That concludes our training. Good job, everybody. That was a lot of information. So now I hope you have a birth preference sheet. I could speak about every single one of those points for at least an hour. There's a lot of information, so I don't want anyone to go away feeling like I've taken a birth class just because you did this hour training. I hope that you learned a lot. This was really fun, and there's a lot more to learn. So please keep learning. And on the call, I'll personalize the steps needed for you to feel confident and prepared for birth. So we'll figure out what you know, what you don't know, where are the gaps, and I'll clarify okay, it sounds like these are the things you're needing to work on. And so you'll walk away with that, and that in itself can be really helpful. And then we'll explore if my coaching program would feel like a good fit for you. So go ahead and book that call. And I look forward to seeing you there, and maybe at any other future trainings too.